Hello, everyone, and welcome to today's webinar, HDV, the most severe form of viral hepatitis, what you need to know about it, presented by Drs. Valentina Svicher and Anna Avellon. I am Alexis Krause of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by DiaSorin. To learn more about our sponsor, please visit www.diasorin.com. Now, let's get started. Before we begin, I would like to remind everyone that this event is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. We'll answer as many questions as we have time for at the end of the presentation. If you have trouble seeing or hearing the presentation, click on the Support tab found at the top right of the presentation window, or report your problem by clicking on the Ask a Question box located on the far left of your screen. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located at the top right of the presentation window and follow the process to obtain your credits. I now present today's speaker, Dr. Valentina Svicher, Associate Professor of Virology at the Department of Experimental Medicine and Surgery, University of Rome Tor Vergata, Italy, and Dr. Anna Avellon, Head of the Hepatitis Unit at the Spanish National Center of Microbiology, Instituto de Salud Carlos III, Madrid, Spain. For a complete biography on our speakers, please visit the Biography tab at the top of your screen. Dr. Svicher and Dr. Avellon, you may now begin your presentations.
Thank you for this kind introduction, and today we will talk about insights and emerging concepts into a peculiar pathogen that is hepatitis B virus, HDV. HDV is the smallest RNA virus. However, it can cause the most severe forms of hepatitis. HDV is very peculiar since it can establish an infection only in presence of another virus, and this helper virus is hepatitis B virus, HBV. Indeed, HDV uses the surface glycoproteins that are produced by HBV to infect the hepatocytes. This means that HDV and HBV share the same surface glycoproteins, and this in turn means that anti-HBV vaccination can be active also against HDV. Another peculiarity is represented by HDV genome that is composed by a highly stable circular RNA molecule. After the entry into the hepatocytes, HDV genome migrates into the nucleus, where it is either transcribed or replicated by human RNA polymerases. Furthermore, HDV genome encodes only a single protein that is defined as delta antigen. The production of a single protein by HDV genome, and particularly the lack of viral polymerase, have limited for several years the identification of effective pharmacological targets against HDV. HDV can be transmitted parenterally, sexually, and vertically, and however, the most efficient way of acquiring HDV infection is the parenteral transmission. In particular, it has been estimated that even very, very low doses of HDV, up to 10 to minus 11, can establish an infection. And this poses some concerns on injection drug users that represent an important reservoir of HDV infection. In particular, this recent study led in San Francisco has shown that over a third of injection drug users with a chronic HBV infection are also HDV seropositive. There are two types of infection, co-infection and superinfection. Co-infection means the simultaneous infection by both HBV and HDV. Co-infection is associated with the resolution of both infections and with a 3–4% risk to develop fulminant hepatitis. In the setting of co-infection, the development of antibodies against HDV is transitory. So this means that it's not possible to define the real burden of individuals undergoing co-infection with both HBV and HDV. A completely different scenario is represented by superinfection. Superinfection means that an individual with an already established chronic HBV infection gets infected by HDV. Superinfection is associated with an 80–90% risk to develop chronic HDV infection and with a 3% risk to develop fulminant hepatitis. In the setting of a superinfection, antibodies against HDV develop and persist over time. So this means that epidemiological studies aimed at investigating HDV seroprevalence are based on this category of individuals. Chronic HDV infection plays a crucial pathogenetic role. In particular, around 70–80% of patients with a chronic HDV infection develops cirrhosis after 5–10 years after primary infection, and the probability of survival after 10 years is around 40%. Furthermore, chronic HDV infection can also increase the risk to develop liver cancer. In particular, the study led in US has shown that chronic HDV infection is an independent factor significantly associated with an increased risk to develop liver cancer. HDV pathogenicity can be also modulated by viral genetic variability. In particular, HDV is characterized by a high degree of genetic variability that has allowed the virus to spread into 8 different genotypes. This study shows that genotype 1 is associated with a lower survival rate than genotype 2. A peculiar case is characterized by genotype 3, that is the most divergent genotype. In particular, genotype 3 has been associated with severe aggressive forms of hepatitis and with outbreaks of fulminant hepatitis in South America. The pathogenetic role of HDV strongly supports the importance to set up adequate screening programs in order to identify patients infected with HDV. Which are the typical features of patients with chronic HBV and HDV infection? As shown in this slide, HDV can suppress the replication of HBV by several mechanisms, and this is translated into clinical practice into lower levels of serum HBV DNA and lower rate of HBeAg positivity coupled with abnormal transaminases. The typical feature of HDV dominance can be exemplified in this clinical case. This is the clinical case of a young woman from Eastern Europe. During routine examinations, her transaminases resulted altered, so she decided to come to our outpatient clinic of infectious diseases, where she discovered to be positive to both HBsAg and to antibodies against HDV. Serum HBV DNA was only 80 international units per ml. Conversely, serum HDV RNA was around 7 million copies per ml. Liver biopsy revealed the presence of a cirrhosis. So this is the typical profile of HDV dominance with an end-stage liver disease in a young adult. However, it should be emphasized that HDV dominance is the typical, but it's not the exclusive profile. In particular, as shown in this study, the majority of patients were characterized by HDV dominance. However, 17% of them showed no dominance of either HBV or HDV, and 7% of them showed HBV dominance. These different profiles are associated with a different response to interferon alpha that so far is the only currently available drug against HDV. In particular, and as expected, HDV dominance was associated with the worst virological response to interferon alpha. Conversely, around 60% of patients with HBV dominance or no dominance successfully responded to treatment. This complex interplay between HBV and HDV strongly supports the importance to set up adequate monitoring of patients with chronic HBV and HDV infection for an optimal management. What about the epidemiology of HDV infection? Worldwide, it has been estimated that around 2 million individuals are infected with HDV. However, the geographical distribution of HDV infection varies considerably, and some areas of the world, including Amazon basin, Central Africa, Eastern Turkey, and Mongolia, are considered highly endemic. Particular attention should be dedicated to Africa, in which HDV infection has been for several years neglected. This important study shows that in Central Africa, around 25% of general population is HDV seropositive. In West Africa, around 7% of general population is positive to HDV. This prevalence, this percentage is lower to that of the survey in Central Africa. However, it's still high considering that is based on general population. This study, led in Central Africa, shows that chronic HDV infection is associated with a 30-fold increase in the risk to develop liver cancer, and this fold increase is higher than that observed for HBV monoinfection and for HCV infection. What about Europe? In Europe, HDV seroprevalence ranges from 1% in Finland or Slovenia up to more than 25% in Romania. The introduction of anti-HBV vaccination has determined a decline in the prevalence of HDV infection. However, in the last decade, HDV seroprevalence remained stable over time at around 10–15% of patients with a chronic HBV infection, or in some cases underwent an increase. A similar situation, a similar trend was observed in the US. In particular, different studies have shown that HDV seroprevalence increases from 2% in 2008 up to 12% of patients with a chronic HBV infection in 2016. The stability of HDV seroprevalence or the increase of HDV seroprevalence can be mainly explained by immigrations from endemic countries. And this has led to a new phase of HDV epidemiology in Western countries. Indeed, on one hand, we have domestic patients that are older with a long-lasting infection and an end-stage liver disease. On the other hand, we have immigrants that are younger with a recent infection and often with aggressive forms of hepatitis. Beyond geographical distribution of HDV infection, it's also important to focus the attention on special categories of individuals that can be important reservoir of HDV infection. In particular, this study was aimed at investigating factors significantly associated with HDV seroprevalence in patients with a chronic HBV infection. As expected, the so-called high-risk profile, defined as low serum HBV DNA and abnormal transaminases, was significantly associated with HDV seropositivity. Surprisingly, notably, HCV co-infection was another independent factor significantly associated with a higher risk to be HDV seropositive. This study was also aimed at investigating factors associated with the request of HDV testing, and surprisingly, HCV co-infection, despite being highly frequent, is negatively associated with the request of HDV testing. So this means that HCV co-infection is associated with a reduced rate of HDV screening, and this can be explained by the fact that clinicians mainly attribute liver damage to HBV and HCV, and they don't think about the presence of HDV. Another category of individuals deserving attention is represented by HIV-infected patients. In particular, this recent study shows that around 15% of HIV plus HBV infected patients are also HDV seropositive. The majority of them are characterized by a highly replicating HDV. Again, HDV infection is associated with a higher risk to die for end-stage liver disease, but also with a higher risk to die for all causes. The HDV seroprevalence we have just described can be considered the tip of the iceberg, and this is mainly due to a low rate of HDV testing. In particular, this study led in US has shown that among 1,000 HBsAg positive patients, only 10% of them were screened for HDV. So overall findings emphasize the importance to sensitize clinicians to extend HDV testing, particularly in at-risk populations, and also to set up adequate prevention programs, in particular to set up anti-HBV vaccination programs. Finally, I would like to provide you just a brief overview on the new drugs against HDV. As I told you before, interferon alpha administered for 48 weeks is so far the only drug available against HDV. The goal of interferon alpha is to induce off-treatment remission of HDV replication, implying the achievement of a potential HDV cure. However, response rate is very, very low. Furthermore, anti-HBV drugs cannot affect the production of surface glycoproteins, and so they are not active against HDV. For this reason, the scientific community is trying to identify novel pharmacological targets against HDV. And in particular, so far, 3 new drug classes appear to be promising. In particular, we have entry inhibitors. Entry inhibitors bind surface glycoproteins that are expressed on the surface of HDV particles, thus interfering with the entry of the virus inside the hepatocytes. Then we have the so-called farnesylation inhibitors. These drugs inhibit the farnesylation of delta antigen that is a step crucial for the proper assembly and maturation of viral particles. Finally, we have the so-called nucleic acid polymers. Nucleic acid polymers are polymers of nucleotides, and they can bind surface glycoproteins when they are still inside the cell, in particular when they are inserted into the membrane of the endoplasmic reticulum. These drugs interfere with the binding between surface glycoproteins and delta antigens, thus interfering with the maturation of viral particles. And at this regard, I would like to provide you to describe this study that has been presented at the international conference promoted by the European Association for the Study of Liver Disease. The study shows that the combination of REP2939, that is a nucleic acid polymer, along with interferon alpha, allowed to achieve of treatment remission of HDV replication in the majority of patients, lasting up to 1.5 years after treatment suspension, so implying the achievement of a potential HDV cure. We are at the beginning of a new era. There's a lot of work to do. However, these first results appear to be promising. So, in conclusion, chronic HDV infection plays a crucial pathogenetic role and is associated with a rapid progression towards cirrhosis, decompensated cirrhosis, and liver cancer. Despite the introduction of anti-HBV vaccination, HDV seroprevalence is still high in several geographical regions and also in special categories of individuals, including injection drug users, immigrants, and patients co-infected with HIV and HCV. Overall findings support the importance of a proper screening and diagnosis of HDV infection. And now I have finished with my talk, and Dr. Avellon will talk about another important topic on HDV infection, that is diagnosis. Thank you so much.
Thank you, Valentina, for your presentation, and good morning, the audience. First of all, I would like to thank the organizers for the opportunity of participating in this webinar. This is about a topic, the Delta virus, that is not common in scientific meetings. In fact, this disease is considered a forgotten disease. As we have just received comprehensive information about the virus and the disease in the previous talk, I will focus on the diagnosis of the hepatitis delta virus infection. As I have mentioned, the hepatitis delta virus infection is considered a rare and forgotten disease by the Orphanet web. This virus is not only rare because of its apparently low frequency, but also, as we have seen, due to its particular structure and taxonomy. This defective virus, fairly described in the 80s, which co-infect with hepatitis B virus, is the smallest known virus able to infect mammals, and is also the unique virus of the Delta virus genus. The genus has not been assigned to any taxonomic family. Additionally, no specific antiviral treatment for hepatitis delta virus had been described, and it may be related to the fact that the extreme simplicity of the virus makes it difficult to find targets for the antiviral treatments. A Delta virus epidemic is linked to a hepatitis B virus epidemic, and thus its solution is focused on resolving the B hepatitis epidemic. However, it has been estimated that more than 250 million people are currently infected with the hepatitis B virus, accounting in the African and Western Pacific region for near 70% from the total. All these persons are on risk of suffering Delta virus co-infection. Then, when and who do we need to diagnose the hepatitis Delta infection? The first question we have to do is, are clinicians aware enough about hepatitis Delta virus? What is said in the guidance documents? Well, there are no specific hepatitis Delta virus guidance documents in the main clinical societies. However, there are some comments regarding Delta virus in the hepatitis B management guidelines of WHO, the American Association of Liver Diseases, the AASLD, the ESL, the European Association for Liver Diseases, and the Asian Pacific Association of Liver Diseases. The 2016 WHO document entitled Action Plan for the Health Sector Response to Viral Hepatitis in the WHO European region indicates that most countries do not have reliable data on Delta virus prevalence. However, it is known to be endemic in some countries of the Eastern Europe and Central Asia, and approximately 15 million people across the world are chronically co-infected with B and Delta virus. It also states that it has been estimated that about 50% of patients are not diagnosed of hepatitis viruses, also including Delta hepatitis infection. Besides, in the WHO fact sheets, it is remarked that all chronic hepatitis B virus carriers are at risk for infection of Delta virus, and that important additional risks of Delta are people who inject drugs, people having high-risk sexual behavior, and migration from countries with high Delta virus prevalence. In 2017, the document of the European Society of Liver Diseases entitled Clinical Practice Guidelines of the Management of Hep B virus infection points out the necessity of including systematic diagnosis of Delta virus infection in the initial assessment of subjects with chronic hepatitis B virus infection. It also underlines the importance of the complete diagnosis of co-infections in order to apply an appropriate hepatitis B treatment. The 2015 document of the Asian Pacific Associate for Liver Diseases, which is entitled Clinical Practice Guidelines on the Management of Hep B, comments that other causes of chronic liver diseases should be systematically looked for, including co-infection with hepatitis Delta virus. It also includes a remark about the hepatitis B recurrences in transplant patients. It is at high risk, this recurrence in patients having Delta virus infection. However, the most recent guidelines of the American Association for Liver Diseases, which were released in 2018, this year, this document entitled Update on Prevention, Diagnosis and Treatment of Chronic Hepatitis B, are the unique guidelines, including a specific recommendation about hepatitis Delta virus screening. There are the following recommendation. Antibodies anti-Delta virus as a screening is recommended in a person having HIV positive, persons who inject drugs, men having sex with men, and all other people having at risk of sexually transmitted diseases. Also, a patient with low levels of DNA of hepatitis B, but having elevated ALT levels may be considered for Delta screening. And finally, immigrants from areas of high endemicity of this infection, of Delta infection. In this guidance, the countries that are mentioned are the following. In Africa, especially West and Horn of Africa, Central and Northern Asia, Pacific Island, Middle East, and several countries of the eastern of Europe, some Mediterranean regions as Turkey. In South America, especially Amazonian Basin, and other countries as Greenland. We also have more information about the prevalence, and we would like to focus on these countries, like Iran, having 17% of hepatitis B infected people also having hepatitis Delta infection, Romania more than 20%, Mauritania near 30%, or the Amazon Basin near 42% of people with hepatitis B having also hepatitis B infections. In these American guidelines, also reinforce the need of retesting periodically those patients at high risk of Delta infection. For those with antibodies, also they recommend a periodic assessment of RNA of the virus. And finally, the document says that if there is any uncertainty regarding the need to test, an initial test of anti-HDV is recommended. These comprehensive guidelines regarding Delta screening from the American Association might be related to the reported results of this study that I have been presented here, and it was previously mentioned by Dr. Svicher. This study concludes that the percentage of hepatitis B patients tested for Delta, although it is increasing since 2008, it still remains very low. Less than 5% of the patients infected with hepatitis B are screened for Delta virus infection. The same study demonstrates a growing number of newly diagnosed Delta virus patients from 2008 to 2016 in the USA, with an estimation of about 11% of the patients having hepatitis B having also hepatitis B Delta co-infection. Then, screening recommendations are scarce, and the clinical guidelines, and also according to some author, a revision is needed to call for Delta screening in all chronically infected by hepatitis B patients. So, in this context, with few recommendations, what are the clinician habits about hepatitis Delta virus screening? We think that we should ask clinicians about it in order to know if they are aware enough about the Delta virus infection. So the second question is how to diagnose the Delta virus infection. Do we have available enough methodology for do it? The Delta virus may be acquired simultaneously with hepatitis B virus or afterwards. In both cases, the available laboratory parameters are total antibodies anti-HDV, antibodies anti-HDV of the class IgM, Delta antigen, and RNA of the Delta virus. The RNA of the Delta virus is the first parameter that is detected after the incubation period in the acute phase. And also, in the case of chronic infections, when it is positive, it demonstrates active infection. Both total antibodies and IgM class antibodies can be detected the first 1 or 2 weeks after the beginning of symptoms. IgM class antibody decrease with persistence of total antibodies in case of persistence of infections. The Delta antigen would also demonstrate active infection. However, testing of this antigen is currently not recommended due to problems related to sensitivity and reproducibility of tests. And regarding IgM class antibodies, although this is an initial market of recent exposure of the infection of the virus, the IgM class antibodies may persist in a large proportion of patients having chronic infection. Consequently, it's not always a market of acute infection. That's why antibodies of the IgM class against Delta virus currently are not recommended for assessing acute infection. This parameter has been sometimes used as surrogate market for viral replication, but currently is not considered to be 100% sensitive or specific for this purpose. So, regarding the two parameters that we can use for assessing Delta virus infection, what are the pros and the cons of using Delta RNA or total antibodies anti-Delta virus? Well, regarding RNA, the RNA of Delta virus has less stability in the sample, and detection and especially quantification may be less accurate. In negative, it does not assess previous contact. If positive, the RNA suggests active infection and is currently considered a replication market. Regarding total antibodies anti-Delta virus, the interpretation of results of these antibodies in case of a very recent exposure may require the study of an initial and a follow-up sample. Although this parameter does not assess active infection, but we know, because it is said in the literature, that more than 80% of cases with positive antibodies have also RNA detectable. Okay, and regarding the total antibodies, we can say as a pros that is an easy test to perform, and it may indicate not only active infection but also previous contact. Antibodies are more stable in sample regarding pre-analytical phase, and its results are considered very accurate. Regarding RNA of Delta virus, the troubles in the accuracy of PCR techniques used for detection and quantification are related to several facts. One of the facts is that the virus is a very variable virus with high mutation rate in its RNA, and this virus has spread out into at least 8 different genotypes. Consequently, the PCR system able to detect and quantify all genotypes are really difficult to design. Besides, the PCR systems are also difficult to perform, as the circular RNA has a high GC content and extreme auto-complementarity, near 70% of auto-complementarity. This feature determines that, being single-stranded, the viral RNA adopts something like a double-stranding conformation, and this requires a strong denaturation process that should be done previous to the amplification cycles. So there is another problem, is that currently there is no reliable standard for Delta virus RNA quantification assays, as the current WHO standard that was released in 2013 is currently considered not to be enough accurate. Regarding clinical use of RNA detection and quantification, it's important to choose a kit for RNA quantification that should be assessed if it is prepared or not for clinical use. I'm going to antibodies again. The anti-delta virus assays have also different performance in terms of sensitivity and specificity. In the picture of the left, you can see that method 1 do not discriminate positive or negative results properly, as the method number 2 does, as you can see in the picture of the right. So most marketed tests for assays for antibodies, total antibodies, anti-delta virus, are in the microplate format, and only one was recently adapted to chemiluminescence. And this is a very good, interesting point, because this allows a complete automatization of the process. And also, it would allow this parameter, the antibodies for total antibodies for delta virus, to be included in syndromic algorithms with other viral hepatitis, A, B, and C, for example, as well as diagnostic algorithms for hepatitis B and delta, to do it the diagnosis of both infection in one step. This is an example of a proposed diagnosis algorithm. For example, it can be established that in this algorithm that any positive HBs antigen in the routine testing may automatically add an total antibodies, anti-delta virus. And with this action, we can rule out the possibility of B and delta co-infection. We also can use this parameter, the total antibodies against delta virus, to be added to the routine panel of a patient having chronic hepatitis B in a follow-up parameters that we can use only with in patients with highly risk, epidemiological risk, or clinical suspicion. So to conclude, we can say that although considered the most severe form of viral hepatitis, hepatitis delta virus infection is considered a forgotten disease and currently without a specific antiviral treatment. Only the American guidelines include a recommendation for the delta virus testing in chronically hepatitis B infected patients, focusing on those at risk of delta infection, who are people injecting drugs, HIV positive, or people coming from endemic countries and having high risk sexual behavior. The guidelines also state that if there is any uncertainty regarding the need to test, an initial antibody test is recommended. Recent studies indicate that awareness of clinicians about hepatitis delta virus infection might be low, and as a result, this delta infection, may be misdiagnosed. For the follow-up of the active infection, accurate RNA quantification is still a challenge. And finally, with the recent improvements in anti-delta detection, a one-step hepatitis B virus, hepatitis delta virus infection diagnostic algorithm can be implemented at the microbiology laboratory to provide an early diagnosis of the co-infection. Thank you for your attention, and now is time for questions.
Thank you, Professor Svicher and Dr. Avellon, for your informative presentations. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just click on the Answer a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. So let's get started. Professor Svicher, we'll start with you. Our first question is, can we have HDV persistence in the absence of HBV?
Thank you so much for this question. As I told you before, HBV and in particular HBV surface glycoproteins are crucial for the production of infectious viral particles that can establish new rounds of infection. However, the replication of HDV genome and the production of delta antigen are independent on HBV. They don't require a specific HBV proteins. Furthermore, HDV genome is highly stable and can persist longer inside the nuclei of infected hepatocytes. Based on these assumptions, different in vitro and in vivo studies have shown a persistent production of delta antigen and a persistent replication of HDV genome even in the absence of an actively replicating HBV, so even in the absence of surface glycoproteins. However, the clinical significance of these persistent infection that we can define as a sort of a latent infection has to be elucidated yet.
Now, Professor, is there a role of serum HDV RNA in promoting liver damage?
The role of serum HDV RNA in the pathogenesis of HDV infection has been controversial for several years. However, thanks to the introduction of more robust assays for the quantification of serum HDV RNA, the role of HDV viremia has been better elucidated. In particular, a recent study has shown in particular a positive correlation between the levels of serum HDV RNA and the histological activity in the liver. In line with this finding, another study has shown that the levels of serum HDV RNA are higher in patients with hepatitis and cirrhosis than in asymptomatic patients. And finally, another recent study has shown that serum HDV RNA is a factor associated with a higher risk to develop liver cancer. So overall findings support the existence of a direct correlation between the extent of HDV replication and the extent of liver inflammation and damage.
What about HDV infection in pregnant women, Professor?
Thank you for this question. This issue has been investigated into two studies led in West Africa. And in particular, these two studies have shown that around 8 and 15% of HBsAg positive pregnant women are also HDV seropositive, suggesting the existence of a potential reservoir for vertical transmission of HDV infection.
Dr. Avellon, what can be done from the laboratory side to contribute and improve HDV diagnosis?
In fact, we can contribute by many ways. First, we should have an accurate and clinically validated techniques for hepatitis delta virus in our laboratory. Second, we have to have some type of contact with the clinician to ask clinician about delta viruses, their diagnostic habits, and also to inform the clinician about technical questions that they can have. And finally, I think that we can implement very useful algorithms, and as I have mentioned before, for primary diagnosis and for the follow-up of the infection, trying to do easier and more quick the diagnosis of the co-infection of hepatitis B and delta virus.
Dr. Avellon, our next question is going to be for you also. How can a laboratory manage for HDV screening using only an anti-HDV detection technique?
Okay. Total antibodies assays for Delta virus, they are good techniques for screening. In fact, they are recommended techniques for screening. We only have to have in account that if a very acute infection is suspected, a very recent contact with the virus is suspected, then it may be necessary to study an initial sample and also a follow-up sample, for example, 1 or 2 weeks after. With this way of behavior, we can diagnose every infection, both acute and chronic. Of course, if we have any positive in antibodies, we should submit the sample for RNA detection to confirm an active Delta virus infection.
And now it looks like we have time for one more question. Dr. Avellon, is there any chronically HBV infected patient at risk of HDV superinfection?
Well, in fact, all of chronically hepatitis B infected patients are at risk, are potential risk of superinfection with hepatitis Delta virus. According to the American guideline, we can think that there is a high risk in some specific patient having epidemiological risk, having HIV positive, people injecting drugs, or having a sexual behavior of risk. And of course, we have to pay special attention to patients coming from these countries having a very high prevalence of Delta virus infection. And finally, in those hepatitis B virus infected patients, we should have special attention on those having a specific clinical behavior, that is that having an apparently controlled hepatitis B infection with low or very low DNA of the virus, but the patient have liver disease, an increased level of ALT. This is a clinical suspicion for Delta virus infection, and of course, in all those cases, the infection should be screened.
As a final comment, I would like to stress the importance to set up a proper screening and diagnosis of HDV infection, to set up adequate anti-HBV vaccination program, and to identify novel pharmacological targets against HDV. These are the 3 key points that are crucial for an optimal control of HDV infection. And finally, I would like to thank you and the moderator for this exciting experience.
Thank you again, Dr. Svicher and Dr. Avellon, for your time today and your important research. We would also like to thank Labyrinth and our sponsor, DiaSorin, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand through May of 2019. Labyrinth will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, goodbye.